My name's Angela Farrell and I'm a Clinical Modernisation Facilitator at South Tyneside Foundation Trust.
And I'm Sam Coleman, I'm the Unit Manager on the Emergency Assessment Unit, and I've also got another badge for the Patient Flow Coordinator within the Trust.
And I just need to tell you, who Sam thinks she's going to have a heart attack because she's never done this before.
I've never done this ever before.
Anyway, we're going to talk to you about one of our projects that we've been implementing in our trust around zero borders, and in that project we've been trying to work towards not moving patients between different wards, reducing length of stay and improving standard work across the trust. So in the presentation we're going to tell you about the methods that we've used, how we identified some of the problems and challenges that then created opportunities for us to find solutions and give benefits for our patients, and also some of bringing the teams together, how the challenges and some of the work we did around that. So our methodology of choice in South Tyneside is the Virginia Mason production system, and obviously the focus of Virginia Mason, I'm sure a lot of you will be aware, is around eliminating waste, improving efficiency and looking at value at every stage of a patient's journey to see what adds value for the patient. The first step in any project is always, of course, to define and identify what it is you're trying to look at. And in Virginia Mason we use process mapping and value stream mapping to look at where the challenges are. And this is the map that we use for this project, so I'll let Sam talk you through that.
So basically we all got together and we looked at a patient. You look at that, how confusing is that? This is a patient, so if we all work in that every day, what's that patient thinking? What are they experiencing there? That is their journey into hospital. What anxieties are they having? Look at it from their perspective there. Now this is a lady that had never ever been in hospital in her life. She'd reached the grand old age of 80 odd and arrived at A&E. What goes on in your mind? You don't want to be in hospital, do you? You feel a bit unwell, the GP said you need to go to the accident emergency centre. Oh doctor, I don't want to be going into there, I don't want to trouble them. Didn't want to trouble them. Went into A&E and the doctor said, I think you need to come into hospital for a few days. Few days, this is what's in our mind, champion. A few days, I've got my dog at home, etc. As you can see from that process map, that's not a few days, is it? That lady's stay ended up 3 months. So what did we do wrong there? What's gone wrong in that path? So as you can see, she started in A&E, and you can see by the yellow, that's all the different people she's seen straight away. And the blue is the documentation, all the different pieces of documentation that we used. The pink is the time that we're not doing anything. So initially, if you look at the first section, we're doing a lot. Lots of people involved, lots of questions being asked. This poor woman's, wow, what's going on? Am I really meant to be in this system? Going into the emergency assessment unit, again, lots of duplication of documentation. We're asking the same questions again. And the patient's then thinking, all right, I've been seen by a doctor, I'm going to be in for a few days. And then suddenly, there's lots of pinks, delays, nothing happening. So what kind of day do you think this is? It's a Friday, she's came into hospital. This is a weekend. So this lady, after a few days, if we'd done everything right and had been reviewed on the Sunday, would have been back home, back with her dog in our old place. Busy times on a Sunday, we're all being in the hospital on a Sunday, no beds. Patient flow coordinator, who is the ideal person, the person that's going to go home on the Monday to board. This lady's boarded onto a ward and she subsequently falls on the night. So, as you know, she now then has to see all these different professionals again. She gets moved to another ward, and it's a time to think, do we take this lady to theatre, do we not take this lady to theatre? And again, as the story goes, this lady's in hospital for up to 3 months. And it's not really very good. So, out of that, we all sat down and were very saddened by that experience because we were involved with it. Well, we weren't personally involved, but we were. This is the culture here. We hadn't really thought about the individual. It was really sad, wasn't it? We were really struggling when we looked at it this way. And these are the problems that we identified. It was the number of people this person actually was having to deal with. It was different people. Doctors in A&E, then she went to the assessment unit, doctors in the assessment unit, then she was moved to another ward, and then there was new doctors there, new nurses, new multi-professionals. There was just lots of them all around. The decision to board. There was no standard documentation, so from the A&E documentation was different to the assessment documentation, so she was repeatedly telling people things. And there was no we couldn't actually track what our estimated date of discharge was. Nobody following that process and aiming for it and saying, look, this is Sunday, this lady can get home now. Nobody was doing that. There was no focus. There was no standard assessment of the patient's dependency, and there was no standard communication between all the areas.
So obviously an important part of every project is your measurement and what your starting point is. And you know, from a patient's point of view, when we looked at the start of the project, we had 41 patients on a daily basis, moves of up to 7 wards during a patient's stay, and 88% of our patients were being discharged after midday. And that adds up to a lot of money. One patient for one day for a year is approximately £54,000. So if you imagine you have 41 patients a day, you do the maths, that's a lot of money. But most importantly, actually, it's not a good patient experience. And that money we could be investing in our patients and their care. So, how to improve and make things better? Obviously, part of the Virginia Mason methodology is to use Kaizen or rapid process improvement workshop events. So the start of this project was with a Kaizen event, a 2-day event where we involved people from all of the teams involved in the care of the patients coming through the sort of journey we've just described. And it was an interesting event for lots of different reasons, and I guess Sam and I come from, you know, we'll tell you both sides of the story, because we were saying we'd come together as 2 organisations just very recently, a community health services provider and a acute foundation trust. So we were a new team together as well, and I think some of the tools and techniques were new. So, you know, we were coming together as a new team using a new methodology, and obviously there's all the anxiety that provokes in the team, and Sam will tell you a little bit about what that felt like for the people involved.
Well, all of us have been through processes before in the past, and as a ward manager, I have been involved in many. And you sit in rooms for 2 days, you see all these things that need to be changed, and what happens? Nothing. So, understandably, we are a group of unit managers, ward managers, with modern matrons and CBMs, and we sat in this group thinking this is a waste of our 2 days again, because we've done it last year, we did it the year before, and actually nothing's really changed. So it goes into the room, we've all had this discussion, what a waste of time, this is ridiculous, who are going to cover the wards, etc, etc. You've all had that feeling, and sat with what arms folded. And these poor guys must have been thinking, what on earth is going on? Because it's a them and us straight away, isn't it? The defence are sitting there like this, and unprepared. And you know, they introduced themselves and said Kaizen, and I said, Kaizen, what's a Kaizen? Do you know what I mean? It's a new word for whatever, the new buzzword. And we were sitting there with a very negative attitude, because we've been through so much. You know, as an NHS, how much have we been through in the last few years? It's phenomenal, isn't it? And we think, what's it going to do for our patients? Because we're on the wards here, what's it going to mean to us? So they gave us this feel, we're sitting there, and they said, what would you like to get out of the day? And we were saying improve patient care, and you know, to be listened to, and all the key things. And they said, this is what it's about. So we started in my little workshops, and by I tell you, when I turned to drink by the end of it. I was absolutely exhausted. But you know what? I felt an energy. I felt, even though this is something that's going to change here, I felt as if I was being listened to for the first time. It wasn't about what they wanted and what the trust wanted or what the community wanted. It was about, what do you want for your patients? We're being listened to, we're saying, no, this doesn't work, that doesn't work. We're changing that just because of this and that. We're saying, right, so what are you going to do about it? They were actually throwing it back to us, and we had to sit and say what we were going to do about it. And that was very daunting, because we'd never been given that before, ever. And they set off from our groups. This is a key group. One of them sisters there is a very resistant sister. She was the leader of the house. Like, champion, come on, let's go. And she was, I want to go back and do it now. Can we do it now? You know, this is what we're like. And at the end of the 2 days, I'm saying I took the drink because I got the worst project anymore. I said, so how are you feeling? Well, we went in there with this, but like that. You know, it really energised, and it was something I can't even explain. You had to be in the room to feel how the buzz, it left me with a buzz, and this is the work we've done from it. It was amazing.
And it did leave them with a buzz, and they came up with some great work, and the team themselves used the waste wheel to identify all the delays that the waste that some of which has already mentioned, you know, delays in time, patients waiting for things. delays or duplication of documentation, rework, lots of waste in the system, and then use the ideas from themselves to come up with visual ideas of how they wanted to put things right, what those solutions would be, and how they were going to implement them. And the key themes that were emerging were, it was really hard to keep track of what was happening with the patient because there was documentation all over the place. Different professionals had their own documentation, it was stored in different places, on every ward it was stored in a different place, so keeping an eye on what that patient needed and was waiting for was actually really difficult. So the solutions we came up with, the first thing we came up with was the documentation, and we wanted to introduce an integrated document that every healthcare professional would write in. So in one place, in a chronological order, you could instantly see what was happening with the patient, what they were waiting for, what the patient needed. So we've introduced a new document now across the trust that everybody's using together, which keeps the focus around the patient. And actually that was challenging as well for lots of different reasons.
Well, that was my job.
You can see what I had to work.
Can you imagine trying to get a consultant to write in the same place as a nurse, as a physio to write in the same place as an OT? You've got no idea. It was just impossible. And the target, I got told 2 weeks. Yeah. And no joke, 2 weeks. Okay, that was my nursing director. What? So, I mean, we didn't achieve it because the challenges were we had to get everybody on board. We had to get them to understand this. We needed a story. We didn't need all the documentation in different places because it wasn't for the patient. The patient needs to have their own documentation for them, not for the individual practitioners. And that was the challenge. And it's very nervy.
Another thing we introduced at the Kaizen event that the team came up with was the idea of the patient dependency tool, because in that particular lady's journey what we recognised was that we had no way of looking at what was the patient's usual state of dependency or independence and what was there to compare with what they were admitted to hospital with, and that was sometimes difficult to then identify what we were working towards. So it's obviously RAD rated, so you can see that green, you know, if the patient scored green, they would be entirely independent. If they're in the red category, they were very dependent and very unsick. It's a combination of an early warning score, which is used in emergency care settings, which probably a lot of you might be familiar with, but also factoring in a patient's ability to self-care, so how they can manage their usual activities of living, managing to wash and dress themselves, feed themselves, those sorts of things. So we now have, and it's incorporated into the documentation so that we can record what's the patient's usual level of dependency, so we know what we're working towards for that patient, and what's their admitting level of dependency, so we've got that benchmark, that baseline measure. We've collated this information. Interestingly enough, it started to evolve and give us lots of different benefits that we didn't anticipate originally. Because we've been collecting this information from the wards, a snapshot on a weekly basis of what the dependency level is for their patients. So over a period of time we've been able to get a picture now of what almost the workload is like on the ward. So if people are saying they're stretched, it's a really heavy ward, this evidences almost you know, what the teams are saying, and it's being used in conjunction with different data like clinical dashboards, sort of bed turnover, that sort of thing, national benchmark around staffing levels, to look at actually how we've got the right skill mix to look after our patients as well. Another thing we've used it for is if we do have to board patients, we're obviously working towards not having to do that at all, but obviously it is a journey. Actually, who are the patients we should be boarding? Now, if you have somebody who's 3 and 4, for us to keep that patient safe, unless that's their usual level, because obviously theoretically some people will always be in that category, they would not be the best people to be moved from a safety point of view. You know, you'd be looking at who are the people in the green and yellow category. But then again, we've been working with the teams to think, actually, if somebody's in that yellow and green category, so actually they're almost independent, why are they still in hospital? What is it they're waiting for? Can we send them home with support of community teams? So it's evolving and growing as it's going into being used for lots of different things. The other thing we introduced to support the coordination of care was cluster meetings, multidisciplinary cluster meetings. which take place on a morning on the wards at an agreed time, and they start at that time and they last for 10 minutes. And the purpose of these is to focus on the patients, go through in a very snappy, quick way, in an action-focused way. Okay, Mrs. Such and Such, what are they waiting for? What have they had done? Who needs to do what? And allocating action so that the progress is maintained in the patient's journey. What this has meant in real, and again it was an unexpected benefit that just sort of fell out afterwards. Many of the wards have big multidisciplinary meetings that take a full afternoon or a full morning, and actually a lot of the wards have eliminated those now. So these 10-minute meetings, so 50 minutes a week, have now replaced that 2.5, 3 hour multidisciplinary meeting that used to take place. So that's obviously released a lot of time for the staff to care for the patients again. So from the clusters, there are then actions that we then use for leading nicely into our electronic whiteboards that I'll let Sam tell you about.
The whiteboards in the trust were introduced last summer, and the focus really was about bed management. That's what its purpose was for. But we soon realised it was actually a very good communication tool. It was a way we could communicate to everybody within the trust and the outer trust as well. The facilities that it offered was that when a patient comes into hospital, they were put onto the system, obviously into the AAU department, and there's comment sections and little icons there, which is all the the targets, the sequence targets and screenings and things that we have to tick off and see that we've completed. But it also had a bit on the side where it said where the speciality from the consultant does want this patient to go to. Now the nurses can then pick up that information, so we know that, oh, that patient needs to go to cardiology, that means the patient needs to go to respiratory. So everywhere we can see how many patients need to go to them departments. It helps us plan better. So from a bed manager point of view, I can look and see, then I can go onto the cardiology units page, and I can say, oh, there's predicted discharges on there, there's 4 predicted discharges, these patients could be moved to there. Now, in that process as well is the cardiac teams, the nurses, the specialist nurses can then ping into that because, oh, that's for my speciality, are these referrals for me? So my nurse is on the emergency assessment, you can send the referrals, so everything's linked, we can say everybody's work. And it cuts down the amount of telephone calls, how many telephone calls do you do? In the paperwork, how many referrals do you do on that bit of paper? And you know, you think, and that's time savings, because if it's just going on the system and you're sending the referral off electronically, it's flagged up to that individual person because that's their workload, instead of going in the post and then, you know, it gets through and then bounces back to you 2 days later because you haven't dotted the I or you haven't put the O on the end. You know, we've all been there with referrals where they've come flying back because we haven't filled in that bit of paper properly. And now that's eliminated that, and it's actually shaved off a day of people's time in hospital because people have it knowing what's coming in, they can see what's coming, especially the Macmillan teams can see it, so they know when their patients are in hospital, so they can come or they can ring up and say, oh, I see Mr. Such and Such is in hospital, how's she doing, is there anything we can add? So we know the complete story of the patient.
So obviously then we want to remeasure and see have we actually made a difference with what we've done. And God, we were dead excited because we have made a difference. We had a 63% reduction in the number of boarders from when we started the project, a 7.8% increase in the number of patients actually managing to get home before lunchtime, and the documentation saved 46% of time taken, releasing 30 minutes per patient admitted for staff to care for patients. Sustainability is always the hard one, though, isn't it? Putting things in and getting that initial excitement's great, and you felt Sam's energy there, and the team have felt like that, and it has been a buzz and it's been tangible. But obviously we've just been through probably the toughest part of the year in the NHS generally, you know, those winter months over Christmas when it gets really hard. And obviously keeping the team's focus, you know, people come under pressure and things can slip. And, you know, we have had to revisit the whiteboards because under the pressure that people have felt, you know, they weren't being updated as regularly, so some of those old practices were being reverted to. What was useful though was that patient dependency tool we talked about. gave us the evidence to demonstrate that actually the dependency of patients we'd admitted, not only the number of patients but the dependency had rocketed through the roof. So we can say to the teams, yeah, we know it's hard and actually the evidence is there to support you with that. So, you know, we understand and we can work towards, you know, how we make that better and use that evidence we gather and see have we got the skill mix right and things like that. We share the work regularly across the teams. We've got visibility walls in place to feed back to the teams about the good work and keep the focus on the work. And this work originally started off on the medical wards, and we've repeated it across the other areas so that it's being shared across the whole organisation. And obviously, you know, we've come to share it with you today because we're really proud of it. It's always a journey, but you know, we've come a long way. So unless Sam's got anything to add, any questions?